some of these meetings. And welcome again on behalf of iEcho, which is obviously associated with New Mexico Echo and with India Echo, who are helping us to host the meeting. This is obviously a weekly meeting which rotates, and this week it is our turn to try and entertain you. And it's my pleasure to introduce Vikash, who's, as you know, most of you will know, is from the VIT circuit, who's spent a valuable time doing his fellowship in interventional endoscopy in Ghent with David Tate, and a keen advocate of geeks. And I can certainly attest to the value of that platform for supplementing your practical aspects of doing endoscopy in all forms. So he's going to talk to us about the question of taking out pedunculated polyps. And to me, that's polyps that look like cauliflowers. They have a stalk, and you're always worried a bit about the stalk. But I'm sure we're going to learn in more detail how to assess these and what to do. So over to you, Vikash. And please remember to post any questions that you have in the chat box.
Thanks, Prof, for that introduction. Just to confirm, can everyone see my slides?
We can see your slides and we can hear you.
Excellent. Okay, so yeah, as you mentioned, I'm just going to be taking you through a practical approach to pedunculated polyps, hopefully show you a bit of the evidence or also the lack thereof, and then try and make it very practical and go through some of the technical aspects. And I'll play a few videos at the end and hopefully share some tips which I have found quite helpful with dealing with these polyps. So just to start, I have no disclosures. And again, yes, I am an advocate for the Geeks platform. So I think we're all familiar with this. This is the Paris classification, which was published in GIE in 2003. And it's kind of revolutionized the way we assess polyps. It classifies polyps morphologically. But the value of that is it also gives us an idea of their malignant potential, or whether they are currently malignant, and if they are superficially or deeply malignant. And I think we're all familiar with the 1P and the 1S, the 1P being that nodular sessile polyp, but sitting on a stalk. So raised off the luminal wall with a mucosal stalk. And the 1S polyp, which is the nodular polyp, but is sitting flat on the mucosal surface of the luminal wall. But something that we may be a little bit less familiar with, and I included this slide, is there is some middle ground. And the middle ground is the 1SP lesion, or the subpedunculated lesion. And this is important to assess because these lesions may at first appearance look sessile, but they often sit on this very low, broad-based, flat stalk. And it's important to recognize them because the resection strategy for these polyps may differ. These polyps may be well suited to more like something like an ESD to get en bloc resection. Because of that short, very broad-based stalk, they're not ideal candidates for, or sometimes are not ideal candidates for ligation and resecting with a snare. So it's important to recognize them as 1SP lesions, and they do differ between a pedunculated and a sessile. They lie in between, essentially. So these are some of the common difficulties I've personally had, and I find that people do struggle with when it comes to pedunculated polyps. And if you've seen any of my talks before, I always tend to start off with imaging, and make no apologies for that, because again, believe it's the crux of starting off with any assessment. The difficulty in terms of imaging pedunculated polyps is essentially assessing the whole polyp, and it may be sometimes difficult to image that oral end of the polyp and to appreciate the full polyp. I'll then discuss malignant polyps and some of the data regarding them, as well as what defines an endoscopic cure for these polyps, and show you that there is actually a paucity of data particularly for pedunculated polyps versus your flat sessile polyps. We'll then go through some of the complications associated with the pedunculated polyps and look at the techniques to remove them, and talk about some of the nuances with regards to ligation devices and electrosurgical settings, which I believe is absolutely critical and understood and undervalued. So I have often started with this, and again, make no apologies for starting off with imaging. And the argument may be for pedunculated polyp what's the big deal with imaging? Because pedunculated polyps are easily removed in an unblocked fashion because of the stalk. You may argue that I'm going to resect it either way. And that is true, because I think there is value in resecting pedunculated malignant polyps, because you can get them unblocked and use the histology to direct further assessment. But I'll argue that imaging is still the crux, and imaging is still important. And I'll hopefully show you why. And imaging is useful because it guides us to the resection strategy. Where should we resect along the stalk? And you also need to know what type of polyp you're dealing with before, because not all polyps which are pedunculated need to be resected. So just to quickly touch on this, again, imaging, the crux is to look for a demarcated area. So to look at the mucosal pattern and to look at a differing, or an area with a different mucosal pattern. You then ask yourself, is it regular to regular? So is the regular pattern to a regular pattern, which is less significant, that's a pseudo demarcated area, or is it irregular to, regular to an irregular pattern, and that's a true demarcated area. Again, we know there's a whole host of classifications, Kudo, Sano, NICE, JNet, and the crux again is to essentially just try and simplify this. And the way we simplify this is to look at the demarcated area and ask, is it regular to regular, in which case we're not too worried about. But if it's regular to irregular, then we're worried either about high-grade dysplasia or about malignancy. So we then ask ourselves, is the irregular area, does it still have some maintained structure, or does it have absolutely no maintained structure? And that's the difference between a high-grade or superficial cancer versus a deeply invasive cancer. So again, imaging is crux, because this is an example of an inflammatory polyp in the stomach. You can see the rugae in the background. And these polyps don't necessarily need to be resected unless they're causing symptomatology. So it's important to identify them. This is another polyp which was referred to me, which I resected. And again, you can see that it doesn't have the tubular pit pattern of an adenoma. It rather has that broad mucosal base pattern. And this was hanging right off the ileocecal valve. And when it was resected, this is what it came back as, an inflammatory fibroid polyp. This is another pedunculated polyp, and again lacks the tubular pit pattern, but has a round star haematomatous pattern. And this is an example of a Peutz-Jeghers polyp in a patient with Peutz-Jeghers. It's a haematomatous polyp. So again, I think imaging remains important in terms of determining malignant potential of a pedunculated polyp. And some of the difficulties we have imaging these polyps, again, would be accessing the back end or the oral end. So I prefer using the term oral and anal. I know some people use proximal and distal, but it can create some confusion, because does proximal or distal mean going in with your scope or coming back with your scope? And I think using oral and anal just eliminates any confusion. I think we're all quite clear about oral and anal. I'll share this in subsequent slides. So the crux of imaging the whole polyp and looking at the oral end would be to utilize gravity and to be consciously competent. So utilizing gravity and position change. And I'll go through this in a bit more detail in subsequent slides. But then when we're dealing with the malignant pedunculated polyp, there's certain things that confer a risk of spread, or of either distant spread or also lymph node spread. And these are some of the factors which confer that risk. So we might be familiar with the Kikuchi classification that's used for flat polyps. Somewhat different in pedunculated polyps, we use the Haggard classification, which I'll show in the next slide. There has been reports that not only the depth of submucosal invasion confers a risk of distant disease, but the width of submucosal invasion. I think we're all familiar with differentiation, so poorly differentiated polyps conferring a much higher risk of lymphovascular invasion and of lymph node involvement. Presence of lymphovascular invasion, the presence of budding, and a micropapillary component. So these are all factors, histological-based factors, which confer a high risk of nodal disease and may lead one to need subsequent surgery and not, rely on endoscopic cure for these, because the issue with endoscopy for these patients is you don't sample any lymph nodes and you may miss micrometastases to lymph nodes. So this is the Haggard classification. It's essentially divides a polyp into 5 levels. The first level is only mucosa, so you don't have any submucosal involvement. And I think this image just shows that the polyp stalk does actually contain submucosa, and that's important as well. So it's not just mucosa in the stalk. You do actually have the submucosa lifting up. But the crux also is that the muscularis is quite far away, and that's what makes resecting pedunculated polyps in an unblocked fashion quite safe. So a Haggard classification of 1 would show submucosal involvement, but confined to the head of the polyp. 2, it involves the neck of the polyp. 3 goes down the stalk, and 4 goes down to the base of the polyp as well. And why is that important? So this is the initial paper published by Haggard in 1985. And although not big numbers, you can see that patients with Haggard level of invasion of 4 are patients who also had positive lymph nodes. So this has been shown in various studies that once you start having a Haggard invasion of 4, your risk of lymph node metastases starts increasing quite drastically. There have been other papers which showed lymph node metastases with 2 and 3s, but most of these patients also had other high-risk factors in terms of differentiation, lymphovascular invasion, and other aspects as well. And in this paper also, you can see that most patients with the level Haggard classification of 4 had polyps in the rectum. I think this is probably a reflection of bias, because most pedunculated polyps do occur in the rectosigmoid, and there were small numbers. So whether the rectum truly confers a higher risk, it may. We know it does for COVID cancer, but there are some confounders to consider in the study. And in this other paper as well, which was published in 1991, you can also see that a Haggard classification of 4 as well conferred a higher risk of positive lymph node involvement. So we certainly know that depth down the stalk does confer a higher risk of lymph node metastases. And this is some more data basically supporting that by it's a meta-analysis done. And again, you can see that patients who had stalk invasion had a higher risk of lymph node metastases. They also had a higher risk of recurrence, and they also had more aggressive histological characteristics of the polyps, being lymphovascular invasion and poor differentiation. So patients with stalk invasion were subjected to more invasive therapies, and that being surgical resection, even following endoscopic resection, which I think probably is a reasonable route to follow. So this is another meta-analysis which looked at different histological predictors of lymph node metastases. And again, the same factors came in. So depth of invasion, poorly differentiated tumors, tumor budding, lymphovascular invasion, micropapillary components, submucosal invasion, and these all conferred a higher risk of lymphovascular invasion or lymph node metastases. And the recommendation in these patients was subsequent surgery with lymph node dissection. And again, another paper showing a whole host of studies and a multivariate analysis done. And you can see the same factors coming out again. So I think we've got quite good data showing high risk histological factors. So even though you may resect a polyp and it may come back as malignant, these are the factors that you would use to determine whether we can define our patient as having endoscopic cure or whether we need to go back in with surgery and do a lymph node dissection as well. So if they have any of these features, I would certainly refer them for surgery after endoscopic resection, because again, these are histological factors. So you can predict by imaging, but at the end, histology does guide you in terms of further management. And you can see a whole host of studies, and they all essentially show the similar characteristics. And you can see the odds ratios in the region of 7 to 9 for lymphovascular invasion, even higher for poorly differentiated lesions. So again, imaging is the crux, because this is an example of a case report that was taken from 2021. And this patient ended up having a Haggard classification of 3 and ended up having surgery with positive lymph nodes. But I would argue that you could predict this, because if you look at the polyp, there is a depressed area in the center, and you can see it's not a close up, but you can appreciate the demarcated area in the center of the polyp. So you could have predicted the histology and altered your resection strategy accordingly, which I'll discuss going forward. So let's just look at complications of pedunculated polyps. And by far, the major complication for these polyps is bleeding rather than perforation. And again, that submucosal stalk just lifts you well off the muscularis propria. So perforation is by far a lower concern compared to flat polyps. It can happen, but it depends on how low down the stalk you resect. But that stalk does not comprise of muscularis propria, so the risk of perforation is certainly a lot less. In terms of complications, what confers higher bleeding risks? And it's the same factors that we know about for flat polyps. So older age, comorbidities, anticoagulant use, right side of the colon. And these are the same characteristics for flat polyps. But in addition, with pedunculated polyps, we now know that size, both of the head and the stalk, does confer higher risk. Bigger, fatter stalks, bigger, fatter vessels within. That head has to be fed and has to grow. And in order to do so, needs blood. So the bigger the head, the bigger the stalk, the bigger the vessel lying within. And often you can have 2 or 3 vessels within the stalk, and they're not always lying in the center. That's an important concept to remember, and we'll get back to that. But other factors which are less commonly mentioned, which lead to complications, is the cutting mode. And I think this is a very important aspect of pedunculated polyps. I think an under-discussed and under-understood entity is the electrosurgical unit. And it really makes a huge difference when resecting any type of polyp. We need to really be familiar with our equipment and understand the electrosurgical unit, some of the physiology behind it, and our modes. But also what has been shown to increase bleeding risk is low volume endoscopists. And I think this is important, and what we need to head towards in sub-Saharan Africa is developing high volume centers. So looking at a paper which was published in 2021, not too long ago, and they essentially looked at factors associated with immediate bleeding. And they divided it in 3 subcategories, so less than 5 millimeters, 6 to 9, and more than 10 millimeters in terms of stalk width. And you can see above the 10 millimeter range, there was a significant increase in immediate bleeding. And this is reflected in further meta-analyses. You can see in this forest plot that stalk width of more than 6 millimeters conferred a much higher odds ratio for immediate bleeding. And in this study, you can also see that protective factors were prophylactic closure, either with clipping or with endoloops. Injecting the stalk didn't have much of a protective effect in terms of immediate bleeding in this study. But this is somewhat different for delayed bleeding. So this has been well shown to reduce immediate bleeding, but doesn't have a marked effect on delayed bleeding. And I'll show you more data which supports this as well. So again, the same paper, and looking at the various randomized control studies which made up this paper. And you can again see that clipping versus no clipping does have a protective effect in terms of immediate bleeding. You can see that it doesn't have a protective effect for delayed bleeding, but again, this may boil down to technique. I'll discuss that. And the same risk factors come up for risks for immediate bleeding. So larger head diameter, larger stalk diameter, again, are shown as factors for immediate bleeding. But the one thing that isn't addressed in any of these studies is technique. And I think it's not easy to assess technique in a randomized control trial, because how do you do that? And that's why it's often neglected. But in my opinion, this plays a major role. A snare, a clip or an endo loop that's poorly sited is going to protect no patient from bleeding. So yes, you can look at clips versus loops versus doing nothing, but how you place the clip and how you place the loop is essential. So it will result in lots of inter-study variation, and that's the one missing thing that's discussed in papers and technique. But I do get it; it's a difficult thing to include in a randomized control trial. So again, looking at ligation and injection, and this is a meta-analysis with a large number of polyps. Unfortunately, this didn't only include pedunculated polyps. So some of these trials did also include large flat lesions. So it is subject to bias, and you do need to interpret the data with some hesitancy and a bit of a pinch of salt. But you can see that injection did reduce the rate of overall and early bleeding, with the number needed to treat of 4 and 20. And when you compare injection versus ligation, ligation was superior in terms of reducing early and overall bleeding, but again, didn't have much of a protective effect with regards to delayed bleeding. So based on that, what do the societies tell us? So there's some variation between the Americans and the Europeans. The Americans say that for a head size of more than 20 millimeters or a stalk size more than 10 millimeters, we should pre-inject the stalk with adrenaline and consider a ligation device, so prophylactic mechanical hemostasis, either with a loop or with a clip. Subtle variation between the Americans and the Europeans. The Americans, they both choose a head size of 20, but the Europeans use a stalk size of 10, whereas the Americans use a stalk size of 5 before considering prophylactic ligation. So the next question is, where along the stalk do we resect in terms of bleeding? This is one very small study, and I think we also have to interpret with a pinch of salt. And this study showed that the vessel diameter is largest in the base. I think that's something we would expect, and it's smaller near the head. But the circumference the circumference of normal mucosa to vessels is higher in the head. So this study proposed maybe we should resect polyps midway in the stalk, but I think this is a bit of too simplistic, and there are other factors to consider, which I'll discuss. This is something I think is very important, and this is the only study that compared different electrosurgical settings for dealing with pedunculated polyps. So I think the setting that we're all familiar with regards to flat polyps is endocut Q. I think it's probably the majority of us are using that setting. But this setting, this study compared endocut versus forced coagulation. Now, just to remember, that's the yellow pedal versus the blue pedal. And endocut is essentially a alternating current. So you have cut intervals and you have cut durations, and it alternates a cutting current with a coagulation current, whereas forced coagulation is a coagulation current. So what is a cutting current? A cutting current results in more thermal energy. The higher the thermal energy, the more vaporization of cells you have. So if you vaporize cells quickly, you cut cleanly, and you have less coagulant, less carbonization. So that's different as opposed to using a coagulation cut setting where you don't achieve a quick cut, but rather you achieve more of a slow cook or slow burn. And that, I think, is very valuable when dealing with pedunculated polyps. So this study showed basically it used a forced coagulation at a wattage of 25 and an effect of 2, which I think should be a standard setting that we should use for pedunculated polyps. And the outcome of this paper was that complete resection rates were essentially identical. But the big thing that was different is the rate of intraprocedural bleeding. So the idea here is to not quickly cut that stalk and the vessel inside, but rather to slowly cook it. And in doing so, you coagulate that vessel and you reduce the occurrence of intraprocedural bleeding. We do know that slowly cooking and coagulating vessels does confer a delayed bleeding risk, but certainly does reduce immediate bleeding risk. So I think this is a underdetermined factor. So in the other studies that I showed you, a lot of them don't include what coagulation setting was used. And again, this does lead to certain bias and does lead to, it makes it difficult to interpret the studies because technique is important. So if you're using a clip, but you're using endocut, it might have a difference versus using forced coagulation. And this is certainly a setting I've adopted for all of my pedunculated polyps, essentially. So now let's get on to the crux or the meat of the talk, and that's technique. So we've looked at some of the data, and now let's talk about how to approach resecting these polyps. And I think this is key. So we've mentioned this before in the form of conscious competence for colonoscopy and endoscopy in general, but it really is very, very important to have some sort of understanding or basic understanding of colonic anatomy. And understanding colonic anatomy will help you understand which areas lie more anterior, which areas lie more posterior. And using that, you can determine what sort of effect gravity will have with relation to air and water. And we can then manipulate gravity to our advantage by position changes. So turning the patient, and this is the crux, and this is really important to help us optimize access to the stalk, not only to assess the polyp to image the back end or the oral end, but also to gain access to it in order to resect it. And why is this important? You can see in this slide, I think Prof. Thompson is very familiar with this slide, but this is a beautiful slide using double contrast barium studies, and it shows the effect of position change. So that's left lateral, that's patient in the prone position, that's supine, that's the prone position, and that's right lateral. So for example, if you have a pedunculated polyp sitting in the cecum near the IC valve, and you're scoping your patient in a left lateral position, you can anticipate that that polyp head and stalk is going to be collapsed into the cecum. And you might find it difficult to expose that stalk and the head to assess it. But as soon as you turn your patient from the left lateral to the right lateral, you can see that all the fluid simply moves away to the ascending colon. So the reason this happens is because the cecum is relatively medially lying compared to the ascending colon. So in the left lateral, it's going to be lower. And in the right lateral, it's going to be higher. So air is going to sit in the cecum, fluid's going to run down. And why is that important? So I take you back to the example of the polyp that was referred to me. And this polyp was referred because it was difficult to resect. We weren't too sure what type of polyp it was. And I assure you, the only reason why I was able to resect it and not the referrer is certainly not a difference in skill level, but it was simply putting the patient in the right lateral. And when I put the patient in the right lateral, this is what happened. That polyp head fell very nicely away from the cecum in the ileocecal valve. It exposed the stalk beautifully, and it allowed me to assess the polyp, and it allowed me to safely remove it by gaining access to the stalk. So position change, being consciously competent, being aware of gravity is really key and vital to resecting these polyps. So let's go over some of the technical aspects in resecting these polyps. So it's ideal to try and get the polyp down to 6 o'clock. And this is where good basic colonoscopy technique is essential. If you get to the right side of the colon and you have a big, huge loop in the scope, you can't even easily achieve the polyp in the 6 o'clock position. Having a nice, straight, short scope makes this a lot easier. And this makes a difference because the channel of a standard colonoscope comes out at the 5, 6 o'clock position. So it's easier to resect polyps in general at the 6 o'clock position. You then want to ideally have the head in the oral position. So you want the head away from the scope. You want to be looking down the stalk towards the head. You can then pre-inject the base based on size. Now, this I have my own bias and argument against. So I used to pre-inject these polyps, and I've actually moved away from it. I've very rarely nowadays pre-inject a stalk. And I think I've done this for several reasons, and I might have been biased from my training with David, but I think pre-injection gives us a false sense of security. The whole crux of pre-injection is essentially not so much just the adrenaline, but it's the tamponade effect. And I have learned that if a polyp is going to bleed or a stalk is going to bleed, a defect is going to bleed, I'd rather have it bleed in front of me because I know it's bleeding. I can deal with it. I can coagulate it. I can clip it. I can do what needs to be done. But that false reassurance given by the tamponade effect, which wears out after a couple of hours or the next day, can lead to significant clinical consequences for your patients. They might have significant post-polypectomy bleeds, need to be readmitted, blood transfusions, etc., etc. So I've largely moved away, even from the very big polyps, from pre-injecting, and I'll show you that. But again, there's no data to support that. That's my own personal bias. So yeah, I don't have evidence to support that. So again, take it with a pinch of salt. So what you want to do then is essentially fully open the snare and retract the snare into the channel. So I know most assistants get excited when you pull something back to the channel and their first response is to close it. But the snare does not hurt the channel as long as you don't press the pedal while the snare is sitting in the channel. So you open the snare fully, you retract it within the channel. You then place the scope above the head of the polyp and then slowly deploy the snare by pushing out the sheet. And you want to aim the tip of the snare to the back of the polyp so that you can essentially deploy that snare open over the head. Then the crux is to withdraw the entire scope over the polyp with the snare. So basically the snare runs over the polyp and down the stalk. You may get some resistance along the way with the stalk, and that's where you may need to use a bit of a push-pull technique to achieve your position down the stalk. So essentially, you're just shaking the sheet of the catheter and shimming that snare down the stalk. You can then place it to your desired position. We'll talk about that in a moment. And I think this is very important, and this is what I standardly do. So I don't place the sheet of the snare against the polyp and then close the stalk. The problem with doing that is the stalk is blocking your vision and you're not sure what you're trapping in the oral end. So you can trap extra mucosa, you can trap another fold, you can trap the ileocecal valve, you can trap something that can cause thermal injury, and you can end up with a perforation or deep muscle injury, basically unintentionally, by trapping extra mucosa on the back end. So instead of placing the sheet against the polyp and closing the snare, what I prefer to do is withdraw the snare. So you're basically bringing the tip of the snare towards the stalk. And then as you close the snare, you advance the sheet forward. So you know that the back end of the snare is sitting on the back end of the stalk and you're not trapping extra mucosa in between. And I think this just adds an element of safety, especially when you have a big stalk and you can't see what's lying at the back end. So you then place the snare, you close the snare and advance the sheet. Then again, we've been through electrosurgical settings. So my go-to for these polyps is forced coagulation at a wattage of 25 and an effect of 2. And sometimes for the fat, chunky SP stalks, you may need to use a combination of endocut and forced coagulation. And I'll discuss that in subsequent slides. Then there's two ways to deal with the situation. So essentially what you want to do is control transaction speed. The faster you cut the stalk, the less coagulation, the more bleeding. The slower you cut the stalk, the more cooking. But you don't want to obliterate that stalk and have carbonization. So you need to get middle ground between transaction speed. And how do you achieve that? To me, you achieve that by using forced coagulation and sometimes in combination with endocut. But to me, another way to achieve that is by controlling the snare. So there's two ways. You can either mark the snare and ask your assistant to close the snare. But what I have taken preference to and what I do routinely for pretty much every hot snare that I'm doing is I control the snare myself. So the more you squeeze a snare and press the pedal, the faster it's going to cut. If you don't squeeze the snare very tightly and press the pedal, it's going to transact slower. And this is also important when you're dealing with flat polyps. So sometimes you have a flat polyp trapped between a snare. The assistant is squeezing the handle. You just tap that pedal and you hear a click or a snap. What you've actually done is cold snared. So the reason why you're hearing the click is because you've cold snared the polyp. And that defeated the whole point of doing a hot polypectomy. You'll see your defect is a lot more oozy. And you want to avoid hearing that click. You want the electricity to do the work. It's not cold snare. It's not mechanical transaction. It's electrical transaction. So controlling the pressure that you put on the snare helps you control transaction speed as well. And I think what's very useful is to count this out. So if you're handling the snare, or if your assistant is handling the snare, you count out together. 1, 2, 3, cut. Then you're controlling the speed and you're ensuring that you are actually creating coagulation, cooking the stalk and also cooking the vessel. And by doing so, reducing the bleeding rate. So after you transact the polyp, you then want to assess for bleeding. So that's where using a water jet and utilizing gravity is important, because if that stalk is sitting in a pool of blood, you're going to have a hard time seeing it. So utilize gravity to get the blood away from you. If you see any bleeding, the crux is to use two methods. And this, I think we've learned from dealing with ulcers. So using two methods is more effective. And my go-to method would be coagulating the vessel with snare tip soft coagulation. They're using a soft coagulation 80 effect 4, and then also using mechanical ligation. So using through two basically modalities to control bleeding. So back to the question, where do we place the snare on the stalk? And here, I think there's a lot of debate and there's a lot of argument. I think we all can appreciate that A is not the place to place the snare. So here, essentially what you're debating is oncological resection versus the risk of bleeding. So if you're placing it at A, you might leave polyp behind and you also might leave cancer behind. So I think it's well known that we should either go in the middle of the stalk or the base. And here there is some argument between certain societies. The Europeans do it a little bit differently from the Americans, and there's two schools of thought. So the first school of thought is going to the middle of the stalk. And the reason for going to the middle is people feel that if you have bleeding after resecting a polyp, it's much easier to deal with a stalk and clip a stalk. So to deal with post-polypectomy bleeding might be easier if you take the middle. The counter argument is, yes, you've assessed in a high quality imaging, but if you end up with a malignant polyp, you want to get as much of the polyp stalk out as possible, so go low down. Then the argument is, if you go low down, you're sitting near the base, what if you have bleeding? I don't think that's valid, to be honest. I think you can still deal with bleeding low down on the stalk. So how should we approach it? My take is that there is no one size fits all. My take is high quality imaging, again, is the crux. If you find an area of concern, if you find a demarcated area, if you find a depressed area, if you find an irregular pattern, then you are worried about malignancy within the polyp, and then you should go as low as possible. If you don't find any of those features, then you can go a little bit higher if you are uncomfortable dealing with bleeding. So it depends on your level of experience, but high quality imaging, again, is important in making that decision. So histology will tell you if there's malignancy and tell you if your polyp is out and cured, but you don't have that luxury when you need to decide how to take out the polyp. So again, imaging is key. This is one concept that I just wanted to touch on as well. Again, I think it's important for us to understand the physics of the electrosurgical unit and how does cutting actually work. So what happens is we essentially get increased current density, and that results in thermal energy, heat, and that results in vaporization of cells and cutting. So what affects current density? And current density is affected essentially by the square root of the radius. So that if you close a snare to a quarter of its diameter, you increase current density 16-fold. And this is an important concept to remember, and I'm going to show you why. So that leads to the phenomenon of coaptation, and I'll tell you about that in the next slide. So this just goes back to what I was talking about. The higher thermal energy you achieve, so the tighter you squeeze the snare as well, the more vaporization and the quicker cut you get, versus lower thermal energy where you get desiccation, carbonization, and cooking of a stalk rather than chopping a stalk clean off. So understanding your electrosurgical unit is very important, and I think this is a poorly taught and a poorly understood thing, and something we really need to strive to be better at. So coaptation, why is this important? This is important because in theory, you can cause a lot of issues. So in theory, if you have a clip on a stalk or polyloop, and the diameter or the radius at the polyloop is smaller than your snare, when you apply thermal energy, you might not actually cut at the snare. You might actually cut at the loop, and you can get caught out with that. I must say, personally, I've never seen this, but it is described, and I'm going to show you a video of it. The other place where coaptation can come in is the head of the polyp. So if that head of the polyp is sitting on the opposite wall and is just making a small area of contact, you can actually burn the opposite wall. So be very, very, very aware of that and conscious of that. If you struggle and you have a big stalk, big head, and it's touching the opposite wall, what you can simply do is pull the head up right against the opposite wall. So you increase the surface area, you decrease the current density, you decrease the thermal energy, and you don't burn the opposite wall. So instead of fighting it, which sometimes may be tricky, embrace it and push that polyp up against the opposite wall rather than create a larger surface area. So here you can see beautifully coaptation happening. So I'm just going to stop sharing and start sharing a different presentation quickly. And full acknowledgement to, this is a presentation that's not done by myself, okay? This is a presentation by John Anderson. I just think it's really useful to see this video. Can you all see the new slide? Okay. So just watch this. I think this is a beautiful example of coaptation. And look at that. All the energy is sitting in the loop. You're not cutting where you thought you were. And then you can end up with issues like bleeding. So I think that's a very, very beautiful example. I must say it's probably rare. I've never seen it in my time in Ghent or in any of the polyps I've done here, but be aware of the theoretical list. Okay, then just to be aware that this big 1SP lesions, the fatter the stalk, the chunkier the stalk, the chunkier the vessel within. So these lesions may warrant a different resection strategy. Number one, because that stalk might be very short and very flat, and you can't really set a loop around it, and you may struggle to get a margin if you're setting a snare around it. You may end up with a leaving some polyp behind. So these polyps may have some, there may be some role of ESD in these polyps in order to achieve unblocked resection for them. But the other thing to show is that when you're dealing with a chunky stalk and you're using force coagulation, you may struggle to actually resect the stalk. And in this situation, my approach is to use a combination of cut and coag. So I might use coag for a bit, cut for a bit, coag for a bit, cut for a bit, and slowly transact that stalk. And I think this is an important thing to remember, because you might end up sitting on the scoic pedal forever, and then you end up with a lot of carbonization. You end up with thermal energy being transmitted to the base, and you can end up with deep thermal injury. So you don't want to sit on the pedal for too long as well. And you might need to alternate the current. So in the technique section, I mentioned combination of currents, and I think there is a role for combination, but certainly idea is to slowly transact and to cook that vessel within. So I just put these slides up because this is another polyp that was referred to me, and I think you can appreciate that it's quite a huge pedunculated polyp. It's essentially occupying that whole lumen, and it's got a nice, fat, chunky stalk. And why I'm showing this picture is I had an issue with the loop in this patient, and the loop completely displaced. And I did not inject the stalk at all. I purely resected it with forced coagulation. And when the polyp came off, there was absolutely no bleeding. And the only reason I believe I got away with it, there was no loop. I put a clip on afterwards. There was no injection. It was purely the electrosurgical unit, in my opinion, which was key in resecting this polyp. And there are some authorities like Douglas Rex who posted an editorial in GIE, and he also discussed the importance of using the right electrosurgical technique and how that might be even more important than clips, and how all the studies that don't include that might be biased because of that. So I do think it plays a huge factor. So when to clip after resection, I think we are familiar with this. We went through it. So patient-related factors and polyp-related factors. So large head, large stalk, post-polypectomy bleeding, ooze from the resection site. But then some social considerations: patient living alone, poor access to the hospital, no transport, significant comorbidities, no poor family support, so not going to get you in time. In those patients, you may want to consider also using a ligation technique. So this is the final thing, and this creates a lot of controversy and a lot of confusion. Endoloops versus clips, and everyone has their own bias and their own preference. I must say, I think a lot of reluctance to use endoloops comes from not knowing how to use them. And I think technique is really, really essential when using endoloops. I love endoloops. They my go-to. I think they are a brilliant tool. I use them more than clips, but I think the crux is knowing how to use them. I've seen personally many endoloops being deployed on the floor, many endoloops being well-deployed. You only have one shot at the endoloop, and that's where the crux is. So I think technique is key. But there are other considerations. For example, position and access. If you can't access the stalk using a clip, it might be easier to get an endoloop over the head. Once the loop is over the stalk, then you can stabilize the stalk using the endoloop. And so it might have some advantages in there. In terms of the size of the stalk and the thickness and length of the stalk, I think there is a word, it does warrant mention. So remember that the stalks may not have only one vessel. They may have 2, 3 vessels, and you don't know where the vessel is going to sit, mostly in the center, but they can sit on the edges. So the crux is you want to ligate the entire stalk, and you may not be able to achieve this with the clip when you are resecting large stalks and large pedunculated polyps. So there again, I think there's benefit for using an endoloop. And then it's important to consider the cost. So generally endoloops are cheaper than clips. And experience. If you're not familiar with endoloops, you've never used them before, unfortunately, you do have to factor that in. But also, if you're not comfortable, that's where you should probably also send to someone who is more comfortable with resecting these polyps. And a key factor when using an endoloop is communication. I'm going to show that to you in a video. So again, I think there's a role for ESD in some of these lesions, and you can use your traditional ESD knives, or you can use some of the more lesser known knives like the clut cutters and the SP knives. I'm not going to discuss that. And this is the editorial written by Douglas Rex, who also says that there may be some gain using ESD for pedunculated polyps. These are some of my take-home messages, but again, imaging, conscious competence, gravity, position, basics, fundamental. We should strive for high volume centers. Technique certainly matters. We can't prove it in studies, but I'm almost certain that a lot of data is technique dependent. Ligation devices, know your electrosurgical unit. Communication is vital. So I'm just going to share, I'm going to stop there, and I'm going to share a video that is available on Geeks. And remember, we have given pro access to people. So this is available using pro access. And I think this is a really, really good video. It's a nursing video, which shows how to utilize an endo loop. So okay, I've already got it up there, but let me just show you how to search at the same time. So we want to search endo loop. So we want to search pedunculated polyps. All you hit is the search tab. You go to endo loops, you hit the click button, and it will pull up videos with endo loops. And I'm going to play this video for you because I think it's gold. Let's just get that volume up.
I'm in the US at Gent. My colleague Rick and myself going to explain how to use Ligature. So we created a polyp on a stalk, and we're going to try to put a band on it before we're going to cut it through. So it's quite interesting before you use an envelope to understand how it works. This is an envelope from Olympus. With two handles on the system. So this is the handle to close the envelope. That's the thing we only want when the envelope is in the perfect position. And then here we have the catheter. We can bring the envelope in and out of the catheter. That's just interesting to put it over the polyp before we're going to close it. So I'm going to close the envelope. So I bring the envelope in the catheter. I will do that by pushing the yellow button away from me. So I close it gently, and I keep control. And that's important to ask the endoscopist to have a very good view on the stalk and on the envelope. So I'm going to close it, close it, close it, close it, as far away from the polyp on the stalk until I have some resistance. The whole loop is inside of the catheter until this little plastic thing just over here. And now the mechanism is I'm going to push the iron pusher, and I will push the little plastic until the stalk over here. And until this little plastic zips it together, it's still hanging loose when I open it, as you can see. So now the position is perfect, and I can start to close the envelope and bring the zipper to the stalk. So this, at the same time I'm pushing the zipper to the stalk, I bring back the plastic catheter. Otherwise, I will cut the polyp through with this plastic catheter. So I'm going to bring the zipper to the polyp and bring away the plastic catheter. Similar. At the same time, you see, I lose a little bit space, so I close a little bit more. Okay, similar, similar, similar. And I wait until I see the plastic zipper is coming. So I do it very gently, I do it very slowly. And one time now you see the plastic catheter is coming back. Now you see here the zipper. The only thing I can do with the zipper is bring it closer. I cannot open it anymore. It's just one-way system. So I can push it a little bit harder, as you can see. So I make sure the stalk is completely crushed. But I have to take care. I'm not gonna cut through the stalk. The only thing I have to do is let go the snare, the loop. So what I'm doing is pushing the white handle away from me until the very end. And when I'm there, I have to push a bit more. And there's a little hook coming out, as you can see there. that will lift off the catheter, the snare, the loop.
So I think that's a very valuable use of the endoloop. And I know some of the, in fact, I've actually got the Olympus guys to change their training strategy. I know they've been training using the ABBA model. The problem with endoloops is that you have one shot. Once you deploy that bumper, so he's talking about the plunger and the metal thing. So let's call it deploy and open and close. Once you deploy the plunger, it's one-way traffic. There's no going back. So the problem is people don't get visibility. They deploy that bumper, hoping it's in the right position. Then you see, crap, the loop is too high, the loop is too low, it's not well sighted. You need to have vision. You saw, he said, vision is key. Ask your endoscopist to have vision. So the thing I routinely do for these patients is I routinely, essentially, before doing any endo loop with any of these patients, I routinely go through the process with the nurse. So when I have an assistant, which I know is trained and familiar, then I sometimes take a bit of a shortcut. But I make sure that the nurse and I are speaking the same language. Communication is key. So what do I mean by open, close, and what do I mean by deploy? And it's essential to go over that before you attempt it. So the problem is it's not a snare which can open and close, but you can push it and pull it out of the sheath, and you can use that to open and close. So you do have more than one shot. Instead of deploying the bumper, rather make sure you have a perfect position under vision by simply pulling the loop in and out of the sheath. So push the loop out of the sheath, it opens. Position, push the loop back into the sheath, it closes. So your catheter sits snug against the polyp. Then start deploying. But be careful about making it too tight. So what I do is I tighten it. I wait for a couple of seconds because I want to see the head of the polyp turn blue. Then I know I've captured the vessel and I've ligated something. But I don't want to close it so tight where the catheter kinks and you can't deploy, and I've seen that happen, or where the actual polyloop starts digging into the polyp. And this is why I don't also inject, because I feel injection gives you false sense of security. And I feel like it might make the mucosa more friable and might loosen the tightness of the grip you have around with the polyloop around the stalk. And that's why I don't inject. So just to end, I'm going to play you a video. And this is a massive pedunculated polyp, which I've done near the cecum, essentially. So position was quite difficult. Access was quite difficult. The patient was scoped in the morning by different endoscopists, kept the patient up os, and I scoped the patient in the afternoon. So there's no voice overlay, but I'm going to just take you through it. So you can see there's quite a big polyp sitting there. I have assessed the optimal position. I have utilized gravity, and it's easy to know where's gravity. I can see where the water is. So I used the sheet of the snare to basically probe the polyp to expose the stalk. And there you can see a very broad-based, very
Vikash, are you showing the video? Because you're not showing the video just now.
Okay. Sorry, apologies.
I can't see the video.
Okay, can you see?
We can see the video now, yeah.
Okay, sorry about that. Thanks for stopping me. So again, I've utilized gravity. Water, you can see where it is, so you know where gravity is. Again, I've tried to expose the stalk as best I could. I couldn't get it orally because this was sitting right near the cecum, so there was no chance to get that head orally. Using the sheet of the snare to probe it and to expose the stalk. And then you can see that beautiful, broad-based, chunky stalk. Very short, so not giving you a lot of room to work with in order to achieve a margin. So you could argue this could have been an ESD candidate, but I felt it was doable. So I went ahead and basically proceeded to do it. And you'll see I didn't inject the stalk at all. I'm going to just speed this up a little bit, just to save some time. Okay. And when I was happy that I would be able to get an adequate margin. So remember, once you place the loop, you lose margin because you have to cut above it. So the crux was to try to get a margin on this polyp. I did assess it. I didn't feel that it had any malignant features. So I opened the endo loop, tried to get the endo loop around the head of the polyp, essentially. Tried to shimmy it down onto that stalk. And again, the crux is to have vision of everything. You want to be able to see. And that's where communication also comes in again between you and your assistant. So I started withdrawing the endo loop back into the sheet. I'm not pushing the bumper. You don't see the bumper sliding down there. But when I closed it, you can see that's not a great position. I'm risking margin there. I don't have place to place my snare. So you can see I'm too close to the head here. So I'm not happy. I can see that I'm too close. I'm not happy with my margin. So resight the endo loop. And if you simply push the loop in and out, you can get a second chance. You can have as many chances as you want to and only deploy when you're absolutely happy. So I resighted the endo loop. Let's just move a little bit forward. I try to get it lower down on that stalk. There I'm opening the endo loop again, getting it a little bit lower down before closing it. And there I closed it as low as I could on that mucosa. And now I'm starting to see a more exposed stalk and I'm starting to give myself a bit of margin to work with that snare. So now, again, I haven't deployed it. I've just tightened it. And you can see that that head is already starting to turn pale. So I know I've trapped something within it. And now I'm happy that I do have some space to place my stalk. And I also felt that there's absolutely no lower I could have gone. I'm sitting right at the base there. So I didn't think I could deploy it any lower than that. And I'm watching the head turn blue before I decide to deploy. And you'll see the bumper sliding down. So this is deploy, not open and close. And as I deploy, you see the plunger going down and the plunger pushes the little plastic piece. There's it coming down. And then you're in no man's land, or there is no return after that. So there's the metal piece pushing the plunger down, and then you committed. But again, stalk turning pale, polyp head turning pale. So I know I've trapped something within there. And then essentially deployed the endo loop. Let's just forward that. And you can see it's well sighted and pretty much as low as it can go. I didn't think I could get any lower than that. Then proceeded to place the snare. And again, vision is very, very, very important. Do everything under vision. So I placed the snare over the stalk. I'll show you that. Until I was happy, so I had to shimmy it a bit down. It was a bit difficult getting it around that huge polyp head. Shimmied it down. That's not great. So you can see the snare is very close to the head, risking margin. Wasn't happy with that. Resighted the snare. Push-pull, shimmied it a bit more down. And then felt a little bit better. So closed again. Now, vision is key. So this is where the water jet comes in. Because now you've got the snare down, you've got it trapped, and you can't push water through the flushing channel. So you need to, and I didn't have a water jet, so I pulled it towards me and sucked that bit of mucus out. And then looked carefully before I resected to see if I had margin. So I was happy I had margin on this end, flipped the polyp over, happy I had margin on that end. Yes, I couldn't see the oral end, but there was no ways I was going to, and I had to just accept that there was absolutely no ways I was going to get vision. Slowly started transacting, and you'll see slow transaction, not quick cut. Bit of burn, bit of burn, bit of endo cut, bit of forced, bit of endo cut, bit of forced, no carbonization, slowly working through that polyp stalk, and you'll see it come off beautifully with no bleeding. Then the crux is to go back, assess your defect. So I assessed the defect for margin. I was happy there was no polyp in the margin. And I looked within that defect, and you'll beautifully see the artery that was waiting there. So there's the artery sitting in the defect. There could have been another one or two on that side, I'm not sure, but this artery certainly was well ligated and wasn't bleeding. And a huge, essentially pedunculated polyp came out. I just retrieved it with a snare. Okay, so I'm going to stop there. I hope that it was practical. I hope that it was helpful. I tried to present some evidence first and then show you that we don't have a lot, and then present some of my own biases, which you can take or not take. But these are some tips that I found that have helped me, and I hope it was of some value to you as well. Happy to take any questions.
Thanks very much, Vikash. I think that was a tour de force of how to approach these things. I see there's a hand raised by Sianda. Would you like to ask your question? If you're
Hi, Vix.
Hi, Sianda.
Thanks for a great talk. I've just got two questions. One is the position of your endo loop. So if you put your endo loop, it would be at position C. And then how high above that endo loop is it safe to go with your snare? So
Yeah,
that was
okay, let me take your
then
first question before we get to the second one, and I actually forget your second one.
okay.
You do want to leave a bit of margin because you don't want to resect too close to that loop and risk that loop's falling off. But again, you need to have assessed your polyp, look for malignant potential, assessed where that polyp margin is on the stalk, and use that also to base your decision. Generally, with an endo loop, I do try and sit it as low down as possible and definitely resect above it, leaving yourself at least a few millimeters. You don't want to be right on that endo loop because if you cut the right above, that endo loop can slip off. So you do want to definitely leave a few millimeters. That polyp that I showed you does get a bit tricky when you have those short, fat stalks, and there it becomes a bit tricky. But even in those fat, short ones, you could see that good margin away from the loop and good margin away from that polyp. That polyp came back with no margin involvement in terms of adenoma. So you definitely do want to leave a few millimeters between your snare and your endo loop or your clip or whatever you're using. You don't want it to fall off after you resect. Again, if it does, you can still deal with it, but so you need to take into consideration risk of malignancy, length of stalk, risk of bleeding, leave yourself, and then base it on that, basically.
There is one question in the chat box about which of these polyps, which of these stalk polyps can you take off with cold snare? When do you move to thermal ablation, or are all of them require thermal ablation? Because some of them are actually quite small.
Yeah. So again, the issue with the cold snare is you're going to mechanically transact. Those stalks all have vessels. That polyp head needs to survive. It needs blood and nutrients to survive. There has to be a vessel in that stalk. And with cold, you're going to essentially just transact that stalk with no coagulation effect. So I must say, even the small ones, I won't ligate, but I hot and do forced. And if you look at the guidelines, they say hot. They just say ligate when you get more than 20 or more than 5 on the stalk or 10. So still I would go hot. If you just cut over that, you just transact that vessel inside, you're going to get some oozing. You might get away with it. And if you inject, you might get some tamponade effect, which helps you get away with it. But then again, you risk delayed bleeding. So that tamponade and the injection might give you some false reassurance, especially if you do it cold. I would still go with hot for these pedunculated polyps.
Yes.
Again, as far as I know, there's no evidence, and I'm not sure that people have been brave enough to try them cold and publish. So again, a bit of personal opinion there as well, not so much evidence-based, but that's my approach.
So the other thing is when you have these pedunculated polyps, so the pathologist can orientate them, do you ever skewer them down the middle? Because that's obviously one way of preserving them when they go into formalin. So how do you present them to the pathologist?
I must say, I usually just send the whole thing off with the stalk. If you have very little stalk and it's more of an SP lesion, then you can pin it to a piece of board, and that helps the pathologist orientate it. So if there's very little stalk and a big nodule and a short fat stalk, then you can just pin it to a piece of board, and that will help.
One of the problems is that they do actually shrink quite considerably when they go into formalin. So what you think is a substantial stalk doesn't look so much to them. I know one of the old surgeons here was very keen on skewering them. You put it through the center of the stalk, so there's no problem with orientation of it. But that's.
I just wonder what that would do in terms of then getting your Haggard classification and whether yeah,
well, I think the diathermy is key there as well. That's why obviously the more you char it, the less your Haggard classification comes into it.
So they tend to have a cone-like distribution down the stalk with a wider and a smaller bottom. And I'm not sure if skewering it will make that a little bit more difficult to appreciate in terms of your Haggard. So I must say, I haven't seen
people are doing it. I don't think many of the experts do it. But it's something that used to be talked about. And remember, Haggard is quite old. It's not a sort of a new innovation, and it just it's very much orientated towards the surgeons. So it's nice to see you as a physician promoting it. But the definition of advanced adenomas is really based on histology apart from size. But you're obviously saying now that we should be taking into characterization the imaging to determine whether we think it's malignant up front. So I think that's a valuable lesson now. We now have visual means of trying to detect whether this thing is malignant and whether we want really to try and get it at the bottom of the base. There was one question I had with respect to which of these lesions do you tattoo?
Yeah,
and
so
apart from the cecum and the rectum,
yeah,
which lesions do you tattoo?
the issue with these pedunculated things, especially if there's a small stalk, is it can be a bit tricky to find the scar. If you're dealing with a big flat piecemeal EMR, once you have assessed many scars,
We're talking about pedunculated ones.
So if you're worried about malignant potential, I think the crux first is to do a good endoscopic report, 5 folds from the cecum, etc., etc. But if you don't have any obvious identifiable landmarks, then I think there's value in tattooing these lesions, especially if you're worried about malignant potential. So again, imaging, I think, is crux. And I think the point that we're trying to promote is that you can predict histology by adequately imaging and by doing high quality imaging.
Yes. And I'm not sure all of us so we all sort of seem to think that the Irby is the Rolls Royce, but not everyone has an Irby. So I think it's very important that you know your own diathermy machine, and that you know that they all have equivalents of the Irby, the soft cut, the endo cut. There are different names from them, but it's very, you must look at the energy transfer that's occurring with these settings. So if you've got the Irby, it's quite intuitive to follow it, and the support mechanism for Irby is very good. But there are other diathermy machines out there that I think it would be wise to check exactly what you're doing. Otherwise, you do end up with either a hole or something that looks like a braai fly.
Yeah, and not hope that someone has pre-programmed the setting onto your unit. And when that setting may be right, may be wrong, or may disappear, and then you're in a bit of trouble. So I urge you to know your settings and be able to program them yourself in the unit, not just hope that someone has plugged them in already.
There is a comment from VG about if you do have these large polyps and they are against the opposite wall, if you keep wiggling them, then you will dissipate the energy transfer to the opposite wall. But generally that contact, the bigger the better, rather than the narrower the better. So wiggling the polyp, wiggling it during the transection. I'm not sure if you do that and how easy it is to do.
I don't usually wiggle during the transaction. I just control the pressure that I'm putting on the sleigh, and like I'm saying, I might alternate between forced and forced and cut depending on how chunky it is. So just to control the transaction. But once I have that polyp within the snare, I only start cutting once I'm absolutely happy it's in a great position, and then there's no real need to wiggle that thing. But if you're concerned, again, wiggling then might I agree, you might have various surface areas at different points. But that's why I think it might be better, if you're not sure, rather just pull it up against the wall and hold it against the wall with a large surface area than risk it flopping away during the process and transmitting energy there. It's not common, I must say. I haven't seen it personally, but it is certainly described. So crux is to be aware of it.
Any other further questions? If anybody wants to put a hand up, I think that's everything that's in the chat box for just now. Approximately, just one thing as well. These pedunculated polyps are usually between 15 and 20% of the polyps we see. Sometimes in some series it's less. So by and large, they aren't too common, and really big ones are also not phenomenally common. So again, I think when you get the big ones with a big stock, especially if you're a junior, think twice about tackling it, because you don't really want to make a mess of it, and best to get it done right first time. So if it's greater than 1 centimeter, that's the sort of cutoff for malignancy as well, if there's no other features. and for an advanced adenoma. Once it gets bigger than that, think about whether you should be sending it to you or somebody with grey hair who's done a few more than you, because I think it is safer. And I think we don't really know what our true incidence of polyps is in our indigenous population, in the Africans of African descent. So again, we're not seeing so many in those hospitals whose practice is largely based on Africans of African ancestry. So I think
Sandy, can I just ask you? You couldn't see my hand there, so I hope you can hear my voice.
Yes, we can.
All right, thank you.
Thanks, James.
Thanks very
Please
much,
comment.
Vikash. Superb, thank you. Two small comments from the kitchen sink here. You know, I think one should probably be doing tattooing on every polypectomy, because quite honestly, if it's in the middle of the night at 2 o'clock in the morning and it's very serious, and now you're calling your surgeon out of bed and he doesn't know where to start looking, I think that if you're going to go to a polypectomy of the nature discussed this afternoon, you simply should add the tattoo. It takes just another minute of time to do it. Second point I want to make, and that is, we're looking at here at the hole in the patient, but to look at the patient as a whole is sometimes useful when it comes to assessing the arterial risks. That slide that you borrowed there, just for a microsecond, we saw the pulsation of the artery in the stalk. Now that is a serious warning sign for you. If you see a visible pulsation like that, even though it may disappear that with the next moment, it's there. And it warns you there's a big vessel waiting for you there. And if the patient has underlying arterial disease, atherosclerosis or ischemic heart disease, it doesn't necessarily have to have mesenteric disease, but he may have it. And if you cut a calcified artery, you're immediately in another league of trouble. So always, I think, take with your history, a good history to assess, is there underlying vascular disease of any kind, just to caution you a little bit when you get down to it. So those are my 2 comments.
Thanks
Thank
very
you.
much.
Sorry, Sandy, excuse me, Mr. Chairman. Time
Yes.
is of the essence.
Time is up.
We might cut
Okay.
off. Thank you.
Indeed, Chris. Thank you for reminding us that when we're having a beautiful intellectual discussion. Thanks, but that's very naughty of us to run over. And but for all of you who haven't heard the discussion, it is recorded, and I'd just like to thank Vikash and all the others who have contributed to the chat box and verbally. And hopefully we'll see you next week for the pathology. And goodbye to everyone. Thank you.
Thanks very much. Thanks. Bye.